Welcome to AETCM, the Emergency Medicine channel. Today, we're going to discuss a case about one 67-year-old female who came to our ER with complaints of left low into groin pain since past 1 day associated with multiple episodes of vomiting. Shall we begin, sir?
Yes.
So, sir, on initial assessment, the patient was conscious and oriented and was coming to the primary survey. Patient was able to talk one full sentence and was conscious oriented. So, in the breathing part, airway was patent and there was no secretions, and the breathing air entry was bilaterally equal, and the respiratory rate was 22 per minute, and the saturation was 92% in room air.
Okay.
In the circulation, BP was initially we put her on O2 support also, sir, via nasal prongs, as the saturation was in the lower side and little bit suspecting little tachypnea, put her on O2. And in circulation, BP was 150 over 90 mmHg with the pulse rate.
Saturation is 92%.
92. And pulse rate was 99 per minute. And
what is the first sign of hypoxemia? First sign, tachypnea. So anybody is on tachypnea, actually we can keep the patient on oxygen. How do we tell?
So as the saturation might be on the higher side, but patient might be having tachypnea, but when we give O2 support, it will help in reducing the tachypnea.
How do we tell the patient? Many patients who is having sickness like illness, critically ill patient, their work of breathing will increase. When the work of breath increases, the metabolic rate increases. So that can be actually reduce the total metabolic requirement. Okay, so it is better to give oxygen even when the saturation is little higher. The patient is having tachypnea due to a respiratory disease. If the tachypnea is due to anxiety, fear, respiratory alkalosis like that, then it is not. There is no point in giving oxygen. Okay.
Sir, in circulation, but BP was 150 over 90 mmHg with pulse rate of 99 per minute.
Okay.
And disability wise, GCS was full and pupil was bilaterally equally reacting to light, 2.5 mm. And exposure wise, temperature was 97 degree, 97 normal afebrile temperature with GRBS of 309 milligram per deciliter at that point of time. And sir, coming to the adjuncts to the primary survey, we did an ECG. ECG was showing normal sinus rhythm, and we also did an ABG at that point of time, sir. And pH was 7.36 with the PCO2 of 43 and bicarb of 24.6. And sir, we went ahead with the secondary survey. So the history is that she is a known case of type 2 diabetes mellitus, recurrent PSVT for the past 4 years with dyslipidemia, anxiety and subclinical hypothyroidism. So she came to the ER with complaints of left low into groin pain.
What is subclinical hypothyroidism?
So sir, subclinical hypothyroidism, the TSH level will be normal.
What is subclinical hypothyroidism? TSH is elevated without clinical feature. Okay, that is subclinical hypothyroidism. Okay, some conditions we will have to treat, that we will discuss afterwards.
And so she came with complaints of left low into groin pain for last one day, and associated with dysuria and lower abdominal pain. She also had history of multiple episodes of vomiting.
But what is the typical presentation of urinary tract infection? Urinary tract infection, normally they have dysuria, pain during urination, blood in the urine, pus in the urine. A typical presentation.
Back pain.
Back pain is one of the most important atypical presentation of UTI, especially in diabetic patients, female diabetic patients. Other than that, patient can have vomiting, abdominal pain. But back pain, if somebody complains about long-term back pain, especially in diabetic patient, you have to always check a urine routine, because that is one of the condition. Chronic UTI is seen mainly in diabetes. Okay.
But other than that, there was no history of any fever, loose stools, cough, breathlessness, hematuria. There was no history of any travel to the outer state, or no history of any insect bite, or no other histories of any any rashes or any itching history, pruritus histories. So initially that patient had a GRBS of 300. So we started her on initially subcutaneous atrapid was given, and following it we medications. She was having the medications of injection human atrapid 22-22-0 and mixtard of 28 at night dose, and 10 ligliptin 20 mg OD with the Diano.
What type of regime it is? Insulin regime. There are different types of insulin regime. One is you give only short acting 3 times, 4 times, 5 times. Okay. Depending on the requirement, you can increase 6 times or 7 times. That you can decide. So hourly you can give subcutaneous injection. 6th hourly you can give. 4th hourly you can give. That all depends on the situation. What type of regime it is?
Short acting with
combined acting. What is the advantage of that?
So the night time the patient will be in the sleep. So we are giving the long acting mixtard during night time, which will.
Okay, daytime with each meal, before each meal you give one short acting. So night you give mix act, that is 30% of rapid acting insulin. That will cover the surge of the sugar. That high increase in sugar immediately after food will be controlled by this short acting insulin, and slow release of glucose will be controlled by the long acting insulin throughout the night. Okay, that is a different type of regime. Okay.
And also she was having the diabetic oral OHS like 10 ligliptin, metformin, then alprazolam for anxiety, along with the pregabalin, and then patient was also having verapamil, rosuvastatin, and azithromycin 2 mg. And
verapamil started for?
Sir,
he had PSVT. That's why verapamil might have started. That controls the heart rate. Okay.
Then aldactone and lasixtab.
Okay.
So and other than that, there was no allergy history, and last meal was 4 hours before reaching our hospital.
Okay.
Events is like the described. So coming to the secondary survey, sir. Here the patient pulse rate was 99 per minute, BP of 159 per 90 mmHg, and saturation improved with the O2 support. Saturation improved, and tachypnea also mildly reduced. And on clinical examination, GIT, there was suprapubic tenderness present. And other than that, abdomen was soft and bowel sounds were heard, and chest bilateral basal minimal crusts were noted.
Okay.
Following which we did a local CNS.
So what you suspect that minimal crepitation in the chest? What do you think it is now? As of now, when you are seeing a patient like this, she is having bilateral basal crepitations. Saturation is slightly low. What do you think it is? Pulmonary edema. First thing is always because the patient had a past history of cardiac disease. Coming with desaturation, crepitations are there. Then you have to first thinking is always pulmonary edema. Sometimes it can be normal also. Crepitation in elderly can be normal also, but desaturation is there. So we think it as pulmonary edema. Treat for pulmonary edema. That is the first thing we have to do in emergency room. Okay.
And following which CNS examination was within normal. We went ahead with an X-ray of the chest, which was showing minimal infiltrates over the both lung fields, and along with it we sent for the routine lab investigations. So in routine lab investigations, patients procal was elevated.
Okay, procalcitonin indicates
that the patient is having an active bacterial infection. Here the procal was 3.61.
Mildly elevated. So it looks like a local infection.
Rather
a systemic infection.
And CRP was 137
Okay.
initially, and the creatine was 1.84.
Okay.
Serum.
So you have to always calculate the creatine clearance in this patient because he's an elderly individual. Even 1.8 can be sometimes higher. Okay, so creatine clearance will be ideal for this patient to know what is the renal status.
And HbA1c is 13.1.
Okay, so uncontrolled.
Control.
Okay.
We also sent for the serum ketones at that point of time. It came to be
What do you know about HbA1c?
HbA1c will give us the long period, 3-month period, how's the glycemic status of the
3
patient.
months glycemic control and 50% of the HbA1c is last 1 month. Okay, so that also you should remember that 50% of the HbA1c contributed by last 1 month blood sugar. So last 1 month patient's blood sugar is anyway not getting controlled. So it may be high continuously, but now since recent past it is not at all controlled. Okay.
And the serum ketones were also sent, which came to be positive 1 plus.
Okay.
So at that point of time, we started with insulin.
So you think that it is ketoacidosis or ketone alone?
Ketone alone, as VBG was not showing acidosis.
Okay. So what do you think that reason for ketone body is positive?
Maybe because of the infection.
She had any vomiting?
Yeah, multiple episodes of vomiting.
That may be the reason for ketone bodies. Okay. Don't think that ketone bodies are present means it is diabetic ketoacidosis. Because once the patient is receiving at least some, like now you are giving 30, how much you are giving insulin?
20 to
22, something like that. So when we are giving an adequate or subadequate dose of insulin like this, maybe subadequate, patient will never go to ketoacidosis. If you are completely skipping the insulin, or in case of a severe illness only, that requirement is very high, then only patient normally go to ketoacidosis. Otherwise, they normally don't go to ketoacidosis. So ketoacidosis means absolute deficiency of insulin. Okay, here at least we are giving some insulin. It may not be adequate for that infection. So ketone bodies might have produced either because of the early ketoacidosis or it may be due to the vomiting. Okay, vomiting part we have to cover. Okay. Anyway, acidosis is not there.
And repeated GRBS values were also on the higher side despite initial subcutaneous at rapid doses.
Okay.
And we started with the empirical antibiotics. Then
so how do you control the sugar first? First of all, if this patient is having, so in patient coming to emergency room is with an acute problem. She is having acute breathlessness. How do you manage that first? Second thing, how do you manage the hyperglycemia? Third thing, how do you manage the infection? So these are the 3 things we have to manage. How do you manage the breathlessness?
Breathlessness we can initially give supportive O2 support via nasal prongs, and by that via nasal prongs itself, her tachypnea reduced and saturation was improving. Then for the part of hyperglycemia, initially we...
what is your diagnosis for breathlessness? Are you finding any infection in the lungs?
So counts were elevated.
Do you see any infection in the lungs, or it is part of cardiac failure?
So bilateral infiltrates were noted.
How do you know that it is cardiac failure? What is the BNP level?
Sir. Pro BNP was 1942.
Slightly elevated. Okay, more than 500 is elevated. So mild cardiac failure is there. That might have aggravated by the infection because of tachycardia. That might have aggravated. So you have to treat it as pulmonary edema. So how do you treat it? Normally, how do you treat it?
You can start with last 6.
Tell the steps. Last 6 is 3rd or 4th step. What do you do for a patient who is having suspected pulmonary edema in an emergency room?
So O2 support, NIV.
Initially, we keep the patient in propped up position.
Propped up position is first. Ask the patient to sit in propped up position, or you make the bed 45-degree angle. Keep the patient in propped up. Any breathlessness, you have to keep the patient in propped up position. Especially if suppose there is a cardiac failure and patient is fully conscious, you have to give cardiac table. What is cardiac table?
So we can give a table which will thereby the patient can bend down.
That's why we have given cardiac table in emergency room. It is not for eating food. It is cardiac table. So patient can keep his hand like this and he can lean forward. So what is the advantage keeping the patient in that position?
Patient
expanding the lung area.
So you get a maximum expansion of lung area. Anterior part moves anteriorly, posterior part moves posteriorly, and you can use your shoulders to lift your lungs. Okay, this is called as what type of movement? Physiology you might have learned. Bucket handle movement. Okay. If you are lying down, what happens? Even if you are keeping the patient on propped up position and patient is lying down on the bed, what will happen to the posterior part of the lung? That will not expand because most of the lung fields are on the posterior. If you know the surface marking of the lung, most of your lungs are on the posterior part. So if you are keeping the patient on bed and if you are keeping even in propped up position, oxygenation may not improve like what you see. Normally, if you keeping the patient in this cardiac table, leaning slightly forward, then it will be easy for them to breathe. Okay, so any breathlessness, it is always better to keep the patient on cardiac table. But unfortunately, that is used for food, not for the patient care. It has to be used for the patient care. Okay, so it's called as cardiac table, not food table. Okay, so propped up position, first thing. Then oxygen. You start with nasal prongs or NRBM or BiPAP or whatever it is. Ultimately, saturation has to improve. Okay, so two things. Then third one. Then Lasix. You have to give Lasix. So three things has to be done. Okay. Is there any role for morphine? Fentanyl, morphine?
Morphine can be given as an anxiolytic if the
Okay, if
patient.
the patient is having severe anxiety, you can give morphine so that anxiety will be relieved, tachycardia will be relieved. If tachycardia is relieved, how do it help in the patient with pulmonary edema?
Patient's cardiac output.
Cardiac output, how it improves?
So stroke volume means venous return will increase.
Now there is tachycardia.
Preload will increase and
So
cardiac output.
bradycardia means more time to expand the ventricle. Okay. So the diastolic time will increase. Diastolic time increases, then maximum expansion occurs. Maximum blood will be accommodated in the heart and can pump more. So morphine can be given if the patient is not having any contraindication. What are the contraindication for morphine? Respiratory failure is not a contraindication. 1 or 2 milligram morphine subcutaneous, nothing will happen. Hypotension and bradycardia. Same thing. Hypotension, that is the effect of morphine. If there is no hypotension of bradycardia, you can easily give morphine subcutaneous in any breathlessness, including COPD. Okay, it can produce a respiratory center suppression, but only in higher doses when you are giving IV. If you are giving subcutaneous, the anxiety will be relieved, tachycardia will be relieved, so patient will naturally improve. Okay.
And
so these four things you have to do. Then, so first thing is respiratory part, airway has to be taken care. Second thing,
hyperglycemia
part.
So
blood sugars are 300.
300 range.
How do you manage that? Ketone bodies are positive. Whether it is an early phase of ketoacidosis or due to vomiting, we don't know. So we have to treat the hyperglycemia part.
Initially given a subcutaneous.
What is the potassium level in this patient? Is it important to know the potassium before starting insulin?
Potassium level is 4.1.
So there is no need to worry. So potassium is higher. If the potassium is low only, you have to be very careful. So you can start insulin. How do you start insulin now?
So insulin can be given at the dose of 0.1 unit per kg.
Okay, so that is a minimum required dose. But this patient is already taking some 22, 28. So no need to worry about the minimum dose. The first time you are starting, it has to be low dose. Now, whether you can give subcutaneous or IV, that is the question. What do you want to give in this patient, subcutaneous or IV?
So as initially we did not know other patients how the blood counts or how much of infection state was there. So initially we started with subcutaneous dose.
Okay.
And
what is the contraindication for subcutaneous insulin? Is there any contraindication for subcutaneous insulin? Dehydration. Dehydration is the only contraindication for subcutaneous. So if you have to check for dehydration, if the patient is not dehydrated, you can easily give subcutaneous. So you give either subcutaneous or IV, whichever you are comfortable, you can give. Advantage of IV is anytime you can stop and revert back to normal. But subcutaneous, once you given it, it is given. So that you have to be very careful. So anyway, we have started subcutaneous. How much you want to give? Normally, how much you give? 300 is the sugar. How much you give subcutaneous? As a response, like you are getting 300 blood sugar, how much you will advise immediately?
8 to 10.
20 units.
20
Okay.
units.
So that depends on the physician. He give 20, you give 20 units, he may give 25 units. Okay, so 20 units are given. What do you do then?
Then you have to check up on the GRBS at an interval like 45 hours after the initial dose
Okay.
to know whether how's the glycemic status of the patient is.
Okay.
And how's the response to the unit of atropine given.
Okay.
And if it is good and well and good, we will continue with this.
Okay, so depending on the blood sugar, you have to control. Okay, only thing is there is no something called a sliding scale. What is sliding scale?
Sliding scale.
Sliding scale. Depending on the sugar, you are giving insulin. That is not correct. Okay, in an emergency room or in ICU, depending on the sugar, next dose insulin should be never given. Okay, so you have to give insulin and check the sugar whether it is getting controlled or not. Normally, what is done? You doctors wait to raise the sugar. They see the sugar value, 600, you give additional 10 units. That is not correct. Within 24 hours, you have to fix the dose. Okay, you fix the dose like 22, 22, 22, whatever you like, you fix it. Next day, you see what is the blood sugar. Next day, it is not adequate, means you increase the dose. Okay, not that every time when you check it, increase blood sugar, like insulin 1 or 2 doses like that, you should never do in ICU. You have to fix the dose within 24 hours or 48 hours. You have to fix the dose. Then depending on the sugar, then you can adjust next day dose. Okay, so sliding scale is not a scientific thing in emergency room or ICU. Okay, even in ward it is not a scientific thing. Okay. Only thing you can know whether a patient has gone to hypoglycemia or hyperglycemia, so that next day, suppose after afternoon insulin you are giving, before lunch you are giving 20 units. After taking food, 2 hours, suppose the sugar is 400. Don't give insulin that time. Next day, instead of 20, you have to increase to 25 or 30. Okay, so the action should be taken only next day. So after 22, the sugar has shot up to 400, immediately give another 10 units. That is not a good strategy. Okay.
Then
so that's why sliding scale is not recommended in any standard hospitals. But even now, even then, many are using that. Okay.
Here after this, the patient's sugar values were on the higher side, and by that time we got the reports for the lab reports, and we started with the IV fluids along with we have also given IV insulin as
IV fluid. How do it reduce the blood sugar?
So patient
in DK and all, you give IV fluids first, then you can see the blood sugars are coming down.
Patient will be dehydrated. So when we give the IV fluids, it will improve the intravascular circulation.
It will increase the circulation so that the utilization will increase. So even when in diabetic ketoacidosis, when you are giving only fluids, you can see blood sugars are dropping down. Okay. So blood sugar can even drop down without insulin also. When you are giving adequate fluid, rehydration occurs, the sugars will actually come down.
And then later on, we started with the empirical IV antibiotics for the patient.
So now antibiotic. What antibiotic you want to give?
So patient, we are suspecting a urinary tract infection along with the LRTA.
Okay.
So
you are suspecting LRT also now.
Sir, bilateral crepes were noted, and
you are not thinking that it is pulmonary edema. Is there pulmonary edema or infection? Okay. So you want to cover both the lungs and urine. How do you cover?
So gram negative and gram positive cover.
Same organ, same patient, gram positive and gram negative.
Most chance of gram negative.
It has to be gram negative, and the infection might have spread to blood and produces lung infection also. Two organisms in a same patient, it is not common, but in ICU and all it can occur.
So we started with here ticarcillin clavulanic acid injection was started.
What is the coverage of ticarcillin clavulanic acid?
And gram negative coverage is
predominantly a penicillin, extended spectrum penicillin predominantly covers gram negative. It also covers gram positive anaerobes. Okay, so that is started.
And we have sent for other routine investigations at that point of time.
Urine culture
and blood culture were sent before the initial administration of antibiotic. The urine culture came out to be positive for E. coli and was sensitive to...
What is the colony count?
Colony count was 1 lakh
1 lakh.
1
More
lakh.
than 1 lakh is a significant colony count. What is ESPL positive or negative?
ESPL was negative.
Negative. What is the importance of ESPL?
If this extended spectrum beta lactamases, then won't be covered with the
Covered with
the beta lactamase.
beta lactamase antibiotic. What are the beta lactamase antibiotic? Selectrum antibiotics are penicillin. Extended penicillin like your amoxicillin, ampicillin, and ceftriaxone, third generation cephalosporin. Okay, they cannot cover the ESPL. You have to go for higher antibiotic. Now it is not ESPL. What is the sensitivity report?
So in the sensitivity report is that it was sensitive to amoxicillin clavulanic acid, sensitive to gentamicin.
ESBL is negative. It is sensitive to normal amoxicillin clavulanic acid, gentamicin, ceftriaxone.
Resistant to ciprofloxacin.
Okay.
Sensitive to nitrofurantoin.
Okay. Then, so what do you do? Suppose you are getting a patient like this. First day, when you don't know what is the organism, you have started a higher antibiotic. And now you got after 48 hours, you'll get a report. What do you do now?
So you can repeat a procal value.
What you do? When you are in ICU, what do you do immediately? This is the step you have to follow in ICU, not in ER. ER we cannot do anything. We are starting, and you will be shifting to ICU. In ICU, if you are following up the patient, what is the action from your side? You are de-escalate. It is called as de-escalation. Okay, so you are escalating the antibiotic without knowing what is the organism. You think that it is a extended spectrum organism. You are starting a higher antibiotic. When the patient's report came, and now it is not ESPL, sensitive to almost all basic antibiotics, so you have to de-escalate. What antibiotic you give for this patient? So
for this patient, we can de-escalate to the
augmentin is more than sufficient. Augmentin can cover even gram-negative organs. If ceftriaxone is there, that will be a very good choice. Okay.
Then we also received the blood culture report also, which was also showing positive for E. coli.
E. coli. Okay.
And further, we did a USG abdomen also, which was showing like a mild fatty liver with left PCS prominent, and urinary bladder was distended with echogenic sludge.
Free floating echoes.
Free floating echoes. So we are continued with the same antibiotic. And
what is the age of this patient?
So 70 year old.
70 year. What is complicated UTI?
So patient can have multiple comorbidities with multiple system getting affected.
What is complicated UTI?
Assistant.
Urinary tract infection is not getting complicated. That is a different thing. Complicated UTI means what? Is this UTI is a complicated UTI?
Yes.
So risk factor like diabetes, that is the most important. A patient who is having chronic uncontrolled diabetes with UTI, that has become directly complicated UTI. A male UTI, because of the structural deformity, also will become complicated UTI. Complicated UTI means because of some complication, patient is developing UTI. Not that UTI is becoming complicated. Okay, that is sepsis, multi-organ dysfunction, that is a separate issue. But here, since there is a structural deformity like prostatitis, prostatic enlargement, stricture, stone, patient is getting UTI. Or patient is having diabetes, which is an immunocompromised state, there patient is developing UTI. So this UTI is complicated or uncomplicated?
Complicated.
It is complicated. What is the treatment difference between complicated and uncomplicated?
Broad spectrum antibiotics.
Broad spectrum means what? Big antibiotic, costly antibiotic. It is not like that. A complicated UTI require longer treatment because bacteria can hide inside the tract somewhere, especially when there is a stricture, stone. You have to continuously treat this patient for 1 or 2 weeks. Minimum 2 weeks are recommended for complicated UTI. So if this patient, suppose there is no diabetes, only 1 week treatment is enough. Now diabetes is there, you have to give minimum 2 weeks up to 6 months you have to give. Okay, because this patient will again come back with urinary tract infection. So you treat the patient completely with augmentin with 2 weeks. Then you can continue that nitrofurantoin for another 2 to 6 months, depending on the recurrence. Suppose this patient is telling every time I'm getting UTI, diabetes is there, uncontrolled diabetes. It is better to give for 6 months. Because what is the relationship between infection and diabetes?
Diabetes is a state where high immunocompromised patient.
Diabetes will increase the infection. Infection will increase the diabetes. Okay. So both side it is dangerous. So you have to control the infection so that the diabetes will getting controlled. So if you don't control the infection, diabetes will never get controlled. Okay. So you have to give augmentin at least for 2 weeks, since it's a complicated. Then depending on the previous history, controlling of sugar, you can extend the treatment up to 6 months. You can give nitrofurantoin. That's a preventive antibiotic. Okay.
Sir, then during the hospital stay, we have noticed that she was developing multiple vesicles
Okay, all over the
body, initially over the trunk region.
Okay.
And it was like initial macules, then papules, and then later on vesicles was noted.
Okay.
She was also having the fever, and the CRP was on the higher side, which was not subsiding in the later part of the infection.
Okay. So what do you suspect there?
So at that point of time, there was no any history of any travel to the outside states, or there was no history of any insect bite like that, and there was no history of any other symptomatic or any confounding factors. But the vesicle which was most similar to the vesicles seen during the varicella infection, sir.
Okay. So you suspect chickenpox.
Chickenpox.
Okay. What precautions you take if you are suspecting chickenpox in ICU?
So patient has to be isolated. And the one who is caring for the patient should be wearing a gloves, mask, and so the staff who is caring for the patient should not take care of the other patients.
Okay. So you think that this chickenpox will spread like that? Is it chickenpox or so? Is it varicella or herpes?
So this was the first time she was having the infection.
First time when somebody is developing blebs like this, it has to be chickenpox only. But if patient had last time chickenpox, like when she was young, she had chickenpox. Suppose she had chickenpox in the past. Now she is again getting lesions like this. What it can be?
Then it will be herpes zoster.
Herpes zoster. Herpes zoster, normally it will be in a dermatome, single dermatome. That is a dictum. But if you are seeing multi-dermatomal herpes zoster, what may be the reason? Multi-dermatomal. Here it will be like chickenpox only, multi-dermatomal. Many dermatomes you can see chickenpox. Where all you get like this? All immunocompromised, HIV, diabetes, malignancy, steroid. You got multi-dermatomal this one. Will it spread like other chickenpox? What is the mode of spread in normal chickenpox? What is the mode of spread in herpes zoster?
So in mode of chickenpox, it can spread via droplet infection or direct contact.
Both ways. So droplet through the mouth, oral cavity, sneezing, it can spread, and from the lesion also. Here in herpes
zoster, direct contact.
It is only direct contact. So no need to worry like chickenpox, but even then it can spread to other patients. So it is better to isolate this patient. And suppose what precautions what questions you will ask to your staff members?
To wash your hands.
That is anyway you have to do it. Whether the staff had previous history of chickenpox or whether he had vaccinated or not. Okay. If vaccinated, then it is a lifelong protection. If you had a chickenpox in the past, that also will give lifelong protection from external chickenpox. But even then, you can develop an internal problem like herpes lesion. But normally, it will not spread from the patient to healthcare profession. Okay. How do you manage this case?
So so the management part is that you have to start with antivirals.
What antivirals?
You can start with acyclovir.
What is the dose?
10 mg per kg.
IV you are giving 10 mg per kg body weight. Oral adult 800 mg 5 times per day. Or you can give famciclovir
500 mg TID.
100 mg TID. That is also equally effective. So what happened to this patient afterwards?
So we are isolated the patient. Then later on we started with the antivirals. Valaciclor was started.
Okay.
Then isolation and valaciclor with also we have given
Soothing,
soothing,
skin
skin
agents.
soothings were given, and antihistamines and antipyretics were given.
Okay.
Patient's lesions began to crust, and after that, patient has improved.
What is Ray's syndrome?
Ray's syndrome is a complication of the chickenpox, where is
Not the complication of chickenpox. It is something else. It is complication only.
encephalitis, delirium. Patient will have
Patient
nausea,
takes
vomiting.
NSAIDs or aspirin for pain in chickenpox. They experience this problem. Okay. Especially children, chickenpox is not that dangerous like adult. Suppose you see blood in that chickenpox blebs, what do you suspect? Hemorrhagic chickenpox. Hemorrhagic chickenpox is more dangerous than normal chickenpox. Mortality is very high, so you have to be very careful. If you are seeing elderly individual who is having chickenpox and it is hemorrhagic means, then patient may become deteriorate fast. That you have to be very careful. Bleeding tendency can occur. Okay. Okay.
Yes.
Anything else you want to add? You want to add? Nothing. Okay. Thank you.
Thank you.